Now we'll turn our attention to the lungs themselves. And we, of course, know that the left lung has two lobes separated by an oblique fissure. And the right lung has three lobes separated by an oblique fissure and a horizontal fissure. Now, one point that's important to make here, let's use the left lung as our example. Even though we say that the oblique fissure separates the upper or superior lobe from the lower or inferior lobe, notice that the upper lobe isn't really upper and the lower lobe isn't really lower. Notice that the upper lobe actually goes from the top of the lung all the way to the bottom of the lung. And similarly, the lower lobe goes from the bottom of the lung, and if we could turn this around and see the back of the chest, it would go almost to the top of the lung. So the upper lobe isn't really upper. What it really is anterior. And the lower lobe is really posterior. And that's because the oblique fissure is oblique. And so it's obliquely separating the lobes one from the other. So the upper lobe is on the front and the lower lobe is primarily on the back, which of course means auscultation of the upper lobe requires your stethoscope to be on the anterior chest wall, auscultation of the lower lobe on the posterior chest wall. It also means that if we were looking at a cross-section through the chest, let's say a CT scan, that means we would expect to see the upper lobe of the lung near the anterior side of the CT scan and the lower lobe of the lung near the posterior side of the CT scan, regardless of what level that CT was taken at, regardless of whether it's here or here or here or here. The upper lobe will be anterior, the lower lobe will be posterior. And of course, on the right side, we just have to add the middle lobe. And again, we see that the oblique fissure is oblique, so the lower lobe is still going to be posterior. And we see that the upper and middle lobes are basically anterior. So we can say the same thing about auscultation on the right side. What we want to do is now be a little bit more specific about the surface landmarks of these lobes and fissures. So since the fissures are marking the divisions between the lobes, let's talk about where those fissures are on surface anatomy. So what we can say is that the oblique fissure on both the right and the left side roughly parallels the fifth intercostal space. It's actually slightly more oblique than the fifth intercostal space, but that's close enough. So the oblique fissure is roughly parallel with the fifth intercostal space on the right and left side. And then on the right side, we have a horizontal fissure, and the horizontal fissure goes horizontally from the fourth costal cartilage here, straight horizontally from the fourth costal cartilage to the fourth intercostal space, to the fifth rib, to the fifth intercostal space, where of course it intersects the oblique fissure. So the horizontal fissure would be right about there. So now that we know where the fissures are, that means we automatically know where the lobes are on surface anatomy. Since on the left side, the lobes are separated by the oblique fissure, and we said the oblique fissure is at about the level of the fifth intercostal space, we can then say that the upper lobe will be above the fifth rib and the lower lobe will be below the sixth rib. And on the right side, where we have to add the horizontal fissure, since we know the horizontal fissure separates the upper lobe from the middle lobe, and since we know that the horizontal fissure starts at about the level of the fourth costal cartilage, that means on the right side, the upper lobe will be above the fourth rib, the middle lobe will be between the fourth and sixth ribs, and the lower lobe will be below the sixth rib. All of this, of course, referring to the anterior chest wall. So knowing the surface anatomy of the lobes and fissures is going to be important for us for a variety of reasons, one of which is that on the USMLE there are often what are called penetrating wound questions, in which they'll describe a penetrating wound at a particular location and ask you about what organ or what part of what organ is most likely to be injured. So in this case, if we knew which intercostal space the penetrating wound passed through, we would use this information on the slide to help us figure out which lobe of which lung might most likely be injured. Before we go on and talk about the remaining important surface anatomy issues on the chest, let's finish up a discussion of some clinically relevant things about the lung, specifically the lymphatic drainage of the lung. Because, of course, lung disease, particularly lung cancer, spreads by way of lymphatics. So we have a series of nodes that we should be familiar with. Right around the hilus of the lung, we have what are called bronchopulmonary nodes. And so the lung is draining to those bronchopulmonary lungs. Often you'll hear them also referred to as hilar nodes, right around the hilus of the lung. And then the lymphatics from those nodes drain to the tracheobronchial nodes, which are the nodes right around the bifurcation of the trachea into its two bronchi. And then those nodes drain to the bronchomediastinal nodes that are ascending along the trachea in the mediastinum. And then those nodes will drain into what are called the mediastinal lymph trunks, which will drain back to the venous system. And so we can see on this next slide that the bronchomediastinal trunk on the right side will eventually drain into what's called the right lymphatic duct, which will drain into the junction of the right subclavian and right internal jugular veins. And on the left side, the bronchomediastinal trunk will eventually drain into the thoracic duct, which will drain into a similar position on the left, the junction of the left subclavian and left internal jugular vein. So we can sort of generalize that and say that the thoracic duct receives lymphatic drainage from the left side of the chest, the left upper limb, the left side of the head, but also everything below the diaphragm, since the thoracic duct continues down to the abdomen. So all of this area here, everything below the diaphragm on both sides, the left side of the chest, left upper limb, left side of the head and neck, all drains to the thoracic duct. And the right side of the head and neck, the right side of the chest, and the right upper limb drains to the right lymphatic duct, which drains into the venous system on the right side. So now let's turn our attention back to the issue of surface anatomy and the potential for penetrating wounds. And in order to be able to know that a penetrating wound injured a portion of the lung, we need to know where the heart is, so that we know that if it penetrated outside of the perimeter of the heart, then it would injure the lung, but if it was within the perimeter of the heart, it would injure the heart.